thank you so much. And as you will see, the presentation that I will give is really elaborating on what Dr. Sol just has been saying. And indeed, I'm trying to cover the physical activity and quality of life in patients with univentricular hearts. I could describe the different studies that have been done on quality of life. However, I thought it would be more interesting for you that I'm looking for studies in which the quality of life and physical activity of patients with single ventricle physiology are compared with those of healthy people. And secondly, I'd like to compare the situation of single ventricle with other complex conditions, other biventricular complex conditions. Because we really want to see is the group of univentricular heart, the Fontan patients, are they really a specific group of patients, or are they rather an exemplar for the complex heart defects by large? The topic, the subtitle, was indeed physical activity and quality of life. And physical activity, to a certain extent, that pertains to exercise capacity, functional status, what people do in day-to-day life. Quality of life, on the other hand, is more holistic. It refers rather to how do people look upon their life, how satisfied are they with the life that they are leading, and is the life that they have worth living. But you will see that quite a lot of quality of life studies are approaching quality of life also from a functional point of view. And the studies that Dr. Sol referred to are quite often looking at physical functioning, emotional functioning, and so on. We need to bear this in mind when we are interpreting data from quality of life studies. But indeed, let's have a look at the physical activity first. One study that is really informative came from the Munich group and was published in 2009. They investigated the exercise capacity of people with single ventricles in different age cohorts. And the scores in people with single ventricles are indicated here in the red line, and they are compared with the reference data indicated in the dashed line. And you see consistently people with single ventricles are doing worse in terms of exercise capacity than people, healthy people. And also the expected growth in exercise capacity during puberty in males is not that well pronounced in people in boys with congenital heart disease and single ventricle heart disease. Another interesting study came from Gerard Diller. These are data from the Brompton. And interesting in this figure is that you can see how Fontan patients are related to other conditions. And indeed, physical exercise capacity in these patients is jeopardized. But it is not the worst situation ever. If you see here, Fontan patients are doing better than, for instance, congenitally corrected TGA. And even surprisingly, they are doing better than people with an ASD with late closure. So that means that indeed Fontan patients, yes, exercise capacity is jeopardized. No, they are not the worst condition. And in line with these data, or kind of confirming these data, this is more recent data. And again here, Fontan patients compared to other conditions in terms of the distribution of the New York Heart Association classification, functional status, they are not doing that bad. For instance, once again, compared to ASD patients. Very surprising. So the data that I showed so far have to do with what people can do, their exercise capacity. But let's look at what people do in day-to-day life. So again, the Munich group has looked at daily activities in people with single ventricles and compared this with reference group, and in fact they are having the same activity level as healthy people. So to a certain extent we can conclude that people can do less, but they do as much as the general population does. Of course, this says a lot about healthy people. Okay, let's look at the studies on quality of life. Some years ago, Eva-Lena Bratt, a colleague in Sweden, and we have reviewed all the quality of life studies that have been published over the past 40 years. And overall, we identified 234 studies on quality of life in congenital heart disease. And when we look at the specific conditions, then you see that half of the studies are combining different heart defects in their study. The most frequently studied condition is transposition of the great arteries, and the second most frequently condition is single ventricle physiology. Overall, 25 studies were conducted in single ventricle. Of these 25 studies, 8% of the studies were conducted in children with single ventricle, 36% in adults, and 56% of the studies included both children and adults. Since this session is about univentricular heart beyond childhood, I specifically target the studies conducted in adults. 3 studies used SF-36, 2 the New York Heart Association classification, 1 the Duke questionnaire, and 1 childbearing abilities. 1 study used a linear analog scale. And remember what I said in the beginning, and if you would dig a bit deeper into the questionnaires that are mentioned here, they are approaching quality of life from a rather functional point of view. And the linear analog scale, on the other hand, is a more holistic approach of quality of life. This one study that used the linear analog scale was a study conducted in Copenhagen in Denmark. And they found that on a scale from 0 to 100, if you ask patients, how do you perceive your quality of life, the mean score was 82.5, which is pretty high. They matched their patients with healthy controls based on gender and on age. And in these controls, the mean score was 90, which is not that big of a difference with single ventricle. It becomes interesting when you break down the single ventricle group according to their New York Heart Association classification. And it looks like this. A single ventricle patient within New York Heart class 1 is having a quality of life score of 90, equal to healthy persons. People in New York Heart Association class 2 had a score of 80, and in class 3 had a score of 47.5. So this clearly shows that it is not necessarily the single ventricle physiology that plays a role, but rather the functional status of the patient that determines the quality of life of these patients. The studies that has been done and the ones that we reviewed in our literature review came from these countries. And of course, that shows that we are having a rather limited view on the situation of Fontan and single ventricle patients all over the world. There is an opportunity to learn more from the Approach-IS study. And Approach-IS was an international study that we conducted in 24 centers from 15 countries in 5 continents. And overall, we included more than 4,000 patients with congenital heart disease, and we looked at the patient-reported outcomes of these patients. Of these 4,000 patients, more than 160 patients had a Fontan circulation. So we looked into the details of this group, and so far 3 papers have been published in this matter, and one of them was already mentioned by Dr. Sol in his presentation. What did we learn from these specific analysis? In Approach-IS, so patients, 160 patients coming from all over the world, the mean score on quality of life was 76.4. We did not have healthy controls in Approach-IS, and that's the reason why we compare them with ASD and VSD patients, because it can be assumed that these people represent a benign condition and therefore have a good or at least a better quality of life. And indeed, their quality of life was slightly better than that of single ventricle. And slightly in terms of effect size, if you do inferential statistic, a univariable regression analysis, then you do indeed see that there is a statistical significant difference in quality of life between ASD-VSD versus Fontan group. However, if you look at potential mediators, we found that the illness perception, which means how do people look upon their condition and to what extent do they think that they have an impact and what are the consequences of their condition, then you see that the relationship between the defect and the quality of life is fully mediated by these illness perceptions and is no longer significant for the direct relationship. So there is no direct relationship. It is mediated through illness perceptions. Another interesting finding of the analysis was when we looked at geographic differences. When you have a look at the scores in ASD-VSD patients indicated in the white bars here, you see indeed, according to the continents, that there are differences. People in Asia are doing worse compared to Europe, and North America patients from North America are doing best. But this finding is not found in people with Fontan circulation. There are hardly any differences, geographic differences in the Fontan population. This was very fascinating to find. Another opportunity of Approach-IS is that we can compare the data from single ventricle patients, the Fontan patients, with other complex conditions. And these are unpublished data. Complex conditions that scored better, sometimes only slightly better, are truncus arteriosus, pulmonary atresia, double outlet ventricle, and transposition of the great arteries. Complex conditions that scored lower than single ventricles are cyanosis, people with consistent and persistent cyanosis and Eisenmenger, people with tricuspid atresia, CCTGA, and finally people with conduits. Once again, this is a picture that Dr. Sol already showed. Indeed, we looked, and especially for this presentation it is relevant since we are talking about physical activity and quality of life. We looked at the relationship between this physical activity and the quality of life. And when we did univariable analysis, we found a relationship. But indeed, once again, when you put other factors into play, you see that the relationship is mediated by general health and by New York Heart Association classification, and no longer the direct relationship is significant. So we learned already a lot about physical activity and quality of life, but are we there yet? The answer is no. A UK group has recently, they have developed a research agenda on single ventricle heart conditions. What should be investigated? And in this research priorities, you can find an indication that we need more research on exercise. What are the effects of regular physical exercise on the well-being and the outcomes of the patient? What types of exercise are beneficial? And what are the benefits of exercise rehabilitation? In terms of living with a single ventricle heart condition, once again, here we are talking about a more holistic approach related to quality of life. What are the frequencies of symptoms, limitations, and quality of life? What about lifestyle choices? Long-term social, psychosocial, and other non-clinical outcomes? And how can we improve the care? What are the models of care needed to target the specific needs of these patients? Another opportunity to learn more about this is a new study that we are currently starting up. It is Approach IS2. And whereas Approach IS1 comprised 24 centers from 15 countries, right now we have more than 80 centers from 40 countries that signed up to participate. Unfortunately, only one center from Italy signed up, so we are very much open for having more centers from Italy and also more centers from abroad the world. If you're interested to participate in Approach IS2, please find me after this session. So let me come to the conclusion. In this presentation, I tried to uncover the following. Exercise capacity in people with single ventricle physiology is lower than that of healthy controls. Physical activity level, however, is in line with that of healthy peers. The quality of life largely depends on the functional status and illness perception, and therefore always bear in mind when you read papers that looked for predictors of quality of life in a univariable way. There are many mediating and moderating factors. We did not find any geographical differences around the globe, and exercise capacity and quality of life in people with single ventricle, it shows that it is not the worst complex heart defect in terms of these outcomes. Thank you very much for your attention.